Hello there, and welcome to a day in the life of an emergency physician. I am such a sleepy emergency resident physician. My name is David Delnegro. With me today is little partner in crime, Gare Bear. I have several cats who may or may not make cameos along the way. They are unpredictable. Um, and if you're here, you're probably interested in a little bit about emergency medicine, what we do, why we do it, the good, the bad, the ugly, the in-betweens of it. So um, let's dive right in. So what we'll cover tonight, why you should choose, or first, why I chose emergency medicine, and then why you should choose emergency medicine, besides the fact that it is unequivocally the best specialty, the good, the bad, everything we talked about earlier, and question and answer. A little bit, real briefly, who we are at MST. We've been doing this for 15 years, pre-medical, MCAT, USMLE. We've been doing it a long time. We do it well. We enjoy what we do. And anything from like admissions process to test taking to content, you name it, I'm sure we do something with it. And I think I see the boss in one of those pictures too. Oh, what a small world. And a lot of us are residents and attendings and med students too. So like it's a beautiful cycle. So to jump right in, why choose emergency medicine? So I love doing like 6 things at once. Always have, always will, combined type ADD, ADHD. So man, EM fit like a glove. The ability to do all these things at once, fast pace, the adrenaline junkie. I actually did before when I was in undergrad, emergency medical services or EMS in the state of New Jersey, and loved it. Loved the organized chaos, loved the critical thinking involved, loved the fact that you have to MacGyver stuff a lot. I can't tell you how many times patients who are of larger weight distributions get stuck, they fall and get stuck under things that don't really allow them to get out. On the 3rd floor, under a sink. And you've got to use that big brain of yours to figure out a way to give them good care and get them to the ER. And it's the same thing in emergency medicine itself. Once it's brought into you, hopefully nicely packaged, but in the ambulance, what's coming your way, you never know what's coming. It could be a nosebleed. And even the things, even when you read it on the board, it could be nothing. It could be life-threatening. A nosebleed is most often a 5-year-old or 7-year-old digging for gold. And that's usually you send them home and they're fine. Every once in a while, it's an 80-year-old male who's on multiple blood thinners who's having a life-threatening nosebleed that you need to act upon. So the wide variety really speaks to me. You've got to be ready for everything that sort of comes through that door. So for those of you who are undergrads who are thinking about emergency medicine, you might want to look at sort of a similar track that I did. And that's starting off with emergency medical services or ambulance work. I highly recommend, there's a couple different ways to sort of get experience to see if you want to do it. So ambulance work is one, scribe work is another, tech work is sort of a third. And I really enjoyed the ambulance work because nowhere else do you really get to be by yourself and be young than the ambulance. I mean, people who do hospital work, it's great. But like when you are an EMT or you are a paramedic, you're kind of on an island out there and you actually learn how to be accountable, how to, start swimming when the current comes in. So that's why I'm a big fan of it. But that's how I started in the emergency medicine sort of realm. Now, I really like ER because you sort of get the marriage of high-paced, fast movement medical decision-making, as along with the ability to see instant results sometimes. And a lot of times I'll talk, there's certain cases where you can make a big difference in somebody's life, or even the difference of life or death, in see those results in front of you. And that's awesome. One of my favorite examples is a nursemaid's elbow. And what a nursemaid's elbow is, and it happens usually in relatively young children, 2, 3, 4, is a lot of times it is a child that is walking. They're walking with their mom, or their sister, or sibling. They're trailing behind, and the sister or brother will sort of like kind of tug on them to move a little faster. And if it hits just the right angle, it can cause the radial head here to slide out from the little ligament that holds it together. And it is so painful. And if you've never seen what's called a radial head subluxation or nursemaid's elbow, you think this patient is in they've broken stuff everywhere. And you pick up the history and you go, And you grab their arm very gently and you rotate it and you try and distract them, and then click, you hear this real satisfying clunk or click, and boom, you've fixed it. Now, the child doesn't quite know that yet. They still are, in the pain phase, but you tell the mom, okay, I know what this is. I fixed it. I'll be back in 10 minutes with a popsicle. And you come back with a popsicle in 10 minutes, and the kid wants that popsicle. So you try and distract their good arm, and you make them reach for this popsicle with their quote unquote bad arm. They realize they can use it. You fix them, and the parent thinks you're a wizard. It's so cool. So you get a lot of opportunities like that to make a difference in a short amount of time in stuff like emergency medicine. You also get to do a lot of what's the word I'm looking for? Shared decision making. You get to sit with patients a lot and come up with, these are our options. We could do A, B, C. What do you want to do? So for example, if you're in a smaller, community emergency room, you may not have all the resources 24/7. For example, my residency has a community ER rotation, and if I need ultrasound to come in after 10 p.m., I have to call them. And unless it's a very emergent sort of problem, testicular torsion, intussusception, they're going to tell me, I'll see you in the morning. So if I have someone who may or may not have a gallbladder problem, and it's not relatively emergent or urgent, I have to sit down with them and say, you could take a nap here overnight and wake up and get the ultrasound. You can go home and come back in the morning and get this ultrasound. You could follow up with your primary care doctor in a couple days and get this ultrasound. You have a couple different options. How can I help you find one that works best for not only your medical situation, but your social situation? Some people may not have follow-up with primary care or surgery. Some people may not be able to afford a follow-up with a general surgeon, and that is otherwise not routine. So you get to do lots of complex problem solving with a variety of pathology, and you get to do it at hyperspeed. And you get to do a little bit of everything. I always knew sort of that I wanted to do emergency medicine, but I remember doing my rotations in medical school, and I was like, man, OB-GYN is kind of fun, peds is kind of fun, and all these are kind of fun, but it's way too slow, and I don't like this level of detail. I want to do it faster. Oh, wait, I can do that. I can get the, for neurology, I can do the stroke workup. For cardiology, I can do the heart attack workup. For, pediatrics and OB-GYN, I can do the workups for those things and get a little bit of each of them, while at the same time knowing that if I have a complex question, or if I'm stumped, I can call my friends in those specialties and get an answer and usually learn something along the way. You get a chance to talk to a specialist who does nothing but hem-onc all day. You ask them your hem-onc questions, and now you've gained your knowledge bit. So, and I see there's a couple people here. One is in high school. Congratulations for having such high aspirations so early. That's awesome. I see Alondra here is in her gap year and interested in emergency pediatrics, which is a lot of fun. I actually just came off of my pediatric ER rotation, which is a really good rotation, because you get to fix a lot of people and send them home. Most kids, thankfully, usually have some sort of viral boogers in them, and they can go home, and you can fix them for the most part. That's a lot of fun. So, sort of the next question that I pose to you guys, guys and gals, is what particular aspect about EM attracts you to it, and or what sort of things make you hesitant to choose it? And I've got lots of emergency medicine memes here, and a lot of the sort of they're all based around CAT scans. ER doctors love their CAT scans, so we'll see. There's actually several of them based around the emergency medicine love of, we like to call it the donut of truth. You cannot hide from the donut of truth. So I see a good one in from Brittany, balance of life and working. And that is excellent. You get a great, you hear it a lot, work hard, play hard. ER is the quintessential work hard, play hard. So like as a resident, I in the ER work about 45 to 50 hours per week. Sometimes it's slightly less, sometimes it's slightly more, but that's not bad. I don't know, for residency, I am not complaining. As an attending, you will typically work 30 to 40 hours a week in the ER, and you get the rest of that time to do whatever you want. A lot of my co-residents have side hustles, side gigs, different things that I do. One of our chief residents breeds horses and does I have no idea what she does, but she's great at it. I always see pictures of her on horses. And one of my co-residents is in biotech and like trying to come up with a at-home STD test. Awesome. I do the tutor thing. So, and I get to teach and work with the next generation of residents and students. And some people just like to sleep. Sleeping is a great habit. I wish I did more of it. So you have that great balance of work and life and wellness and the hours. I mean, don't get me wrong, they're hard hours. The shift work is awesome because if you're working from 6 to 4, you're probably out plus or minus 30 minutes from 4. You can schedule something for 7 o'clock at night. It's not like surgery where if you're off at 5 and then this catastrophic case comes in, well, you're there till midnight. And I wanted that. I wanted the ability to plan my days and to plan my evenings, to plan my weekends. Now, the downside of that, because we're doing good and bad, is that like the ER does not close. So like some specialties have a cleaner, normal schedule. It may not be as short as ER, but like a lot of specialties are Monday to Friday with call. And the call itself is usually for only emergent cases only. You're not going to get an endoscope on Sunday unless they're bleeding out, for example. It'll wait till Monday. ER doesn't have that. So like you will work weekends, you will work nights, and that's sort of the trade-off between that. And I'm fine with that. I like random days off in the middle of the week because everyone else is at work and I can do stuff and I can go on little adventures to like theme parks or hikes or all sorts of fun stuff, and there's nobody there because it's a Tuesday in the middle of May or something like that. Just to some of these chats coming through. Again, the thrill, the action, the quick thinking, entirely, like Trevina, agree entirely. That's just why people go into it. You get a chance to make a difference, and you get a chance to see that difference. And then, as Brittany noted, you get a chance to go home at the end of the day. And there is no call. There's, because it's, oh, there's somebody there to relieve you. And if you've got all your charts done and you're at home, you can watch Netflix and eat dinner and do whatever you want with your time and not have a worry that, that there's a likely chance that you're going to be called in to do something. Now, MM notes there's concerns about constantly high stress environment and work. Yeah, that can be a problem. Again, we wanted to talk about the good, the bad, the ugly, honest truths to make sure it's a good fit, or if it's not a good fit, to make sure that you don't get stuck in a field that you don't enjoy. Some people don't like the spotlight of emergencies. They see a crashing patient or a code, their eyes dilate and they want to run. If that's you, probably don't hang out in the ER because that happens a lot. So another problem is overstimulation, overstress. If you wear your work on your sleeve and you live for every high and every low, you can get yourself in trouble because there's a lot of stressful stuff in the ER that's not just the standard pathology. Yeah, the heart attack is very high intensity, high stimulus sort of situation. But you also have things like toxicology emergencies or psychiatric emergencies, stuff like that, that is not life or death, but can drain you a lot more. Because like what happens when a patient comes in and is running around the ER or jumping on beds or something like that? That happens every Friday, Saturday night. There's a cache or a population that come in that are, intoxicated, and we have to take care of them and help them all the same. And that can wear on people a lot of times. So if you're that type A person, you have to make sure to guard yourself against overstimulation, against cynicism or burnout. And the second half of the question goes, any common personal traits shared by those in emergency? There's always the jokes about like there's certain traits between different specialties, and they're true to a certain degree. I'm always reminded of the show Scrubs, which does not talk about ER very much, but they mentioned this one ER doc overnight, and he was just sitting there and just eating peanuts, and he was super chill. And that's sort of the like stereotype of the ER, is that we're super chill. But hello, Gare Bear. Hello, Kit. Oh, this is Caddy. Hello, say hello, Caddy. We have our first cameo of the evening, and Caddy has said hello and would like to leave. Again, attention span. But yeah, so that can happen sometimes, and you have to sort of be ready for that as well. So what to look for in a program, and again, a lot of this seems to be more. We have a lot of undergrads going into med schools. Like, I'm not going to talk as much about like residency searches, fellowship searches, unless that's your sort of thing. Put that in the chat, and I'll mention it. But like, the things that are important about early med school, if you're interested in emergency medicine, is how to get good experience and to figure out if you like it. Like I said sort of in the beginning, EMS is a great way. Your school's emergency medicine interest group is a great way. There's, just shadowing an EM doc or a EM nurse and seeing what they do. Being an EMT or being a paramedic. So a lot of times those are great uplifters for resumes, because like if you've worked as an EMT, or especially if you've like worked as a medic, a military medic or a paramedic, a civilian paramedic for a couple of years, they have no qualms about your ability to like handle clinical situations as a professional who is mature. We have a question coming in from Cressley. Do you know of any online shadowing programs? Now it's tough for ER because ER doesn't sit still the way that family medicine does and the way that internal medicine does, especially for like clinics. You can kind of hang out in a clinic and there's a finite number of rooms and it's a lot more controlled environment. Not to say that they may exist. Ask your local emergency department, if that is such an option, or as we hopefully move into the post-vaccine era, when will they consider having shadowing or volunteers back? A very common thing to do is to be a tech and to like have a part-time job as an ER tech, where you're doing a lot of the basic grunt work. You're moving patients around, you're watching them on one-to-ones. That may be a way to sort of get experience or get knowledge about the department, while at the same time it's something that's feasible during the pandemic itself. And there's always a need for hospital techs. They oftentimes help out an absolute ton, moving around with small pieces of the department that otherwise slow down the flow of the department. And we have our our third and final meme about CAT scans. So there's a couple different types of emergency medicine out there. And some types may appeal to others more than others. It's not a very well-tuned sentence, but I think the point is clear. There is like academic ER, there is research ER, there is community ER, there is urgent care, there is rural ER, and I mean there's overlaps with all these. But like, especially if you're interested in emergency medicine, it's never too early to think about, I would like to do that sort of ER. Because like there's a span of your very large academic quaternary center, your large hospitals, your Cleveland clinics and Mayo clinics and all those large facilities. And then there is Nowhere General in Nowhere, Kansas. +1 if someone can figure out the reference there. What's it called? The big academic ERs are going to have more resources. And a lot of times you function as a triage machine. Now, a lot of ER is triage, and it always will be triage. That's the name of the game. You have 10 patients in there. 7 or 8 of them are probably fine. 1's sick, and 1 is hidden sick. So it's your job to say these 7 are okay to go home. This one who's obviously sick gets this ICU level care, and this one, oh, look what I found. They could have been sick if I didn't pay attention. I'm gonna get them the right resource or the right needs. But when you work in a very large academic center, everything's a little more specialized. So like you don't have to do a lot of things on your own. You may have people there who do your orthopedic splinting for you, who do all your IV, your specialized IV, your procedures for you to a certain degree. And it's your job to basically be sort of a traffic conductor. And, you know, that appeals to some people. And to some people, they want to be, you know, they want to do more stuff. They want to be more hands-on. Now, again, the pros of the academics is that a lot of times you get the cutting edge research first. So like University of Maryland, the emergency medicine, or Cincinnati, ER research powerhouses. When something happens that changes the practice of emergency medicine, and you know, Maryland says do this, a lot of people move their head around and say, oh, that's a good idea. So you're on the cutting edge of developing the next generation of protocols and the next generation of care with the fancy new CAT scanner that, you know, has the 4th generation technology and all that stuff. I'll give you a good example of something that's sort of coming along the way is, you know, they're working on using artificial intelligence to like make MRIs fast, like maybe not CT fast, but like you could get an MRI in the ER and it's not like a 5-hour thing anymore. So you may see people get MRIs in the ER, get more answers and go home, or they might have needed to get admitted for a day or two and get that answer. That's gonna show up in your large academic institutions that can afford those resources and have the infrastructure to develop those protocols. But on the flip side, your more rural or clinical ER, you get to be, even to an extreme sometimes, a cowboy. So if you're in the middle of rural Wyoming, you may be the only horse in town for 2 miles in either, 2 miles, 2 hours in any direction. So like you get the chance to solve some really cool, complex problems. Because like if you have a patient that needs a higher level of care, that higher level of care may be a 2-hour helicopter ride. Do you really need that helicopter ride? Can I handle this in-house? Can I call someone in-house? You have to do, that puts a premium on your ability to improvise and your ability to be creative and innovative. And for someone like me, I'm more interested in sort of that rural community-based ER because you get to solve those complex problems and you get to think of things. You know, I might not have the latest and greatest access to an endoscope that may, you know, solve a problem for a foreign body. But I tell you what I do have. I do have a Foley catheter that normally we use in bladders. And if, you know, if it's within a couple hours and it's, the patient's otherwise stable, I can stick that Foley catheter in, balloon it, pull it out, and look, here's the quarter that patient swallowed. I fixed it without needing the fancy endoscope. So it's sort of a spectrum between the two, the academic emergency medicine that prizes specialization, that prizes, cutting edge research and technology, but it trades a little bit of autonomy. You're more reliant on protocols, you're more reliant on institutional policies and specialists versus your sort of rural or community ER, where you may, so I'll give you an example. There's a hospital in my residency's health network where the ER doc is the doctor overnight. It's like a 30-bed hospital with like a 10-bed ED. It's not very large. Overnight, the ER doctor is the only physician in-house. I believe there may be like a mid-level or two floating around, a resident or two floating around, bunch of nurses, couple techs, but you are the only person with an MD or DO in the hospital. So not only are you answering any calls to the ED, if there's a resuscitation on the floor or a code that happens inpatient, you run up and take care of it. And like, that's super, you're the star of the show running everything. which is kind of cool in my opinion. But for some people, that may be too much. They would like a little more organization involved, a little more sort of framing to help them. And oh, here's our next cameo. Hello, Kit. This is Kit Marie, our little cancer survivor who got lymphosarcoma when she was 1 and is now 3. Get pet insurance for your pets. It'll save you $20,000 when your pet gets unexpected cancer. So, sort of to move by, what's it called, into like some of the, we're moving like towards the second half of this presentation. What questions do you guys have so far about emergency medicine, about the things that we do, and about other aspects of residency or fellowship, which is probably too high a question at this point. I'm gonna take some sips of my water, and yeah, this is very much geared towards what do you guys and gals want to sort of know. And in sort of the meantime, I can sort of start talking about what a typical ER, what a typical day sort of looks like. So normally there is a couple different, normally you come in, a lot of times emergency medicine, the volume is very time and day dependent, like Monday afternoons or though there's a busy time, and a lot of time like Sundays there's not as much. Now of course at any time a major trauma could come in, anytime a heart attack could come in and everything. But usually what you end up doing is there may be a pod or an ER with like 12 or 15 beds. And the challenge of ER is like those 12 or 15 beds or 12 or 15 patients don't necessarily, they're not running parallel to each other. It would be nice if it was like a video game, 10 people came in, you fixed them, you sent them home, you took a break, 10 more people came in. If you have, let's say, a 10-bed pod in front of you, 3 of those patients may be admitted. 2 of them, they may be waiting for beds. 2 of them may be waiting to go home. 5 of them may be active and in different parts. Maybe you just saw 1 or 2. Maybe you're waiting for labs or 1 or 2. And maybe you're waiting for imaging in 1 or 2. So like a lot of emergency medicine is taking a look at everything around you and then what can you push towards its next destination. All right, this patient who had belly pain, who's relatively young, they had a negative CAT scan, they're not nauseous anymore, then they ate food, all right, they can go home. And then coming into that is your next patient, oh, they've got a nosebleed, let me put some packing up there, I'll have the mom hold it for 10 minutes, and then I'll go check on my other patient who just because labs came back and has pneumonia or bronchitis or something like that. So a lot of the job is that sort of parallel thinking. Especially as sort of an attending, you'll manage a pod of 8, 12, 16 people at once, and one of the challenges is you can't get anchored onto the one sick or the one quote unquote interesting case. If a code comes in, everybody's going to a code, but as soon as you stabilize that patient, there's also 3 cough congestions waiting for you as well. And like between seeing that very sick patient, you have to, there's something that's a little more easier. There's like a 6-year-old with ear pain who's got otitis media who just needs amoxicillin to go home. And you've got to sort of alternate between that. And if it's busy, you have to triage, like, okay, there's 3 new patients. One of them is a 9-year-old with a cough and stable vital signs. One of them is a 20-year-old with back pain after lifting a box. They're probably okay for the moment. And then the third one is like an 80-year-old with chest pain. Ooh, that could be something bad. Let me go see the 80-year-old with chest pain, make sure he's in one piece, put my orders in, do my labs. Then maybe I'll see if I can, turn around that 9-year-old with ear pain, get them amoxicillin, get them out quickly, see that back pain, give them some pain medication for it. And then, the cycle sort of repeats itself. Every hour or two, you're seeing and moving a couple patients in each direction. And it's like having multiple treadmills all happening at the same time. That's very much the daily grind of ER. So a couple questions have came in. Fairly easy one from Trinity. Is there a difference between MD and DO as an ER physician? There really is not. Where you sort of see the MD bias is like the neurosurgeries of the world, the dermatologies of the world, especially now that all the residencies have sort of combined. ER is very much a DO friendly field. I don't have the numbers in front of me, but there is no barrier to DOs getting into emergency medicine. So question from Trevino, how can you gain experience if you don't have any yet? And this is sort of, this is good. And this is something like I sort of want to mention several times along the way. Now, again, because of the pandemic, it's not so easy to knock on your neighborhood ER doc and say, let me follow you around all day, because there's still a lot of COVID going around. There's still a lot of restrictions in terms of volunteerism and in terms of like shadowing at this time. Obviously, when we move into a post-pandemic world, fingers crossed, a vaccination world, that will come back. Now, in the meantime, you have some options. What's it called? As I mentioned sort of earlier, getting like a part-time job as an ER tech is one of the easiest things you can do, or a per diem job as an ER tech. You don't have to do a massive amount of hours to sort of learn a little bit. If you've worked in an ER for 1 or 2 months, you kind of know what the gig is about. It is a constellation of mostly well patients with a couple really sick patients mixed in and a couple sick patients that you have to dig and find out what's wrong with them among that. ER tech is great because you learn a little bit about, again, all the little things that move the department forward. For example, in some ERs, the techs do the splints, which is real nice. In some departments, the physicians do the splints. So in some, a lot of times they're bringing patients back and forth to CAT scan or to CT. Probably one of the best things you could do is be like an ER scribe, where you get to work with the physicians directly. And a lot of times, if you ask them, they'll be more than happy to sort of explain, I did this because of this. And like, here's the pearl to recognize that. And a lot of times scribes, you get to notice patterns if you follow around enough residents or attendings or mid-levels. You get to figure out the patterns in like, okay, every attending I work with gets these couple labs for this sort of complaint, this sort of chief complaint. Interesting. And then you can ask them, why do people do this? And then if you notice a difference, most attendings I see do this and you did it a little bit differently. Why? They'll share with you their sort of thought process between it. Again, sort of as I mentioned in the beginning, ambulance work via EMS, EMT, paramedic. For those in the military medics are probably some of the best ones you can do. Now, for a lot of undergrads, you don't have time to go become a paramedic. But many early undergrads have time to do EMT work, and that's what I did. And again, the nice thing about EMT and medic and paramedic is that like you are alone a lot of times when you do these calls. So like I did EMT for a basic life service volunteer rescue squad in my hometown in New Jersey. And when we went out on a call, it was me and also another volunteer EMT. And that was it for 85% of the calls. So like we were alone and we had problems and we had to solve them and we had autonomy. And again, obviously the scope of an EMT is pretty simple. It's get them to the ER in one place, do your CPR if you need to, do your basic interventions. But like you learn a lot about taking ownership and accountability for patient care. You learn a lot about creatively solving problems. Like I mentioned, I can't tell you how many times, you know, an elderly male or female, they would fall in the shower. So common. So common. And your job was to, one, not make things worse because there's a good chance they have a broken hip. Two, get them out of that shower in the first place, wrap them up and get them warm, and then figure out a way to get them out of the house into the ambulance because most people's houses are not made for broken hip management. There's sofas in the way. There's other furniture all over the place. And the amount of creativity and problem solving that EMS teaches you is really invaluable. So in terms of like gaining experience, those are the 3 or 4 that I would sort of suggest. Shadowing when it becomes a thing again, tech work, scribe work, you know, a lot of times, you know, like international experience. I know a couple of people who will do international sort of volunteerism. And like the ERs out there are a little bit different. Actually, they're a lot of bit different for the most part. They're very, you know, they don't have the fancy resources that we have. They may not have a CAT scanner. They may have one CAT scanner that works 60% of the time. And like, what are you gonna do? You're gonna X-ray everything. And you get good at reading X-rays that otherwise in the United States, you would, you would just get a CAT scan for. So, and again, that sort of thinking, hold on, why is this doing that? There you go, we're back. So it's a whole different way of sort of thinking through problems. So we're coming to sort of the last 15-minute mark. We're coming to our last meme here. There is another common joke that ER doctors use ketamine for everything. You use it for procedural sedation, to like put shoulders back in. You can use it for pain control. Traditionally, it actually was mostly used to help calm like the anxiety levels of children who are going to have like sutures, complex suturing, or like some sort of orthopedic procedure. And like now we use it to intubate adults, and we use it for pain medicine and for anxiety and all these different things. So that's another one of these sort of tropes or common jokes about the emergency medicine, is that your patient has the vitamin K deficiency, which is a joke, meaning that they have ketamine coming their way to sort of solve whatever problem may be happening. So as we sort of come to like the last 15 minutes, I wanted to really entertain any other questions you guys have before we sort of like get to the very end here. To sort of summarize the goods of ER and the bad of ER. The good is, you get a lot of variety. You don't know what's coming through the door. There's a lot of autonomy. You get to solve creative problems. You get to see your work a lot of times. You get to see it work, your work. And you can change lives very quickly. You can catch stuff that other people have not seen. You're also a way station for certain things. A lot of times, a family medicine doc may catch something, but they don't have the resource to work it up. No. So like, for example, if a family medicine doc sees somebody who has, a certain constellation of symptoms, they say, oh man, I know it's this. I know it's like Guillain-Barré, but like, I don't have anything I can do about it. You send them to the ER because we have our donut of truth. And then you can get them into the hospital and call the right people. We have a question, and it's from Brittany. Have you ever made a mistake in the ER, and how did you fix it? Everybody makes mistakes in the ER. Thankfully, 95+% of them are very minor errors and very self-correctable. And there are so that is one of the dangers of ER, because everything is going so fast and you're seeing so many patients. And then like a lot of times, if you have multiple patients with like the last name Smith, for example, or the last name like Rodriguez, or some of the more common surnames, you may have 2 or 3 Smiths in your ER, and like, oh no, that amoxicillin you ordered for Jerry Smith is supposed to go for Chris Smith. And like, so a lot of, you're moving so quickly and you're parallel thinking so often that, yeah, mistakes like that do occasionally happen. Everybody makes them, myself included. The nice thing is there's lots of fail-safes, especially like with nursing and pharmacy. So like the nurse will come over and said, I see you've ordered amoxicillin for Jerry Smith. Jerry Smith is here because he has, I don't know, he has a wrist injury. Did you really want to give Jerry Smith amoxicillin? You go, oh no, I wanted to give Chris Smith, who has an ear infection, amoxicillin. So that's probably the most common mistake, is that you're doing so many things that you've got to step back and sort of think about. And that a lot of times what I do to prevent that is, once I've ordered something, I will go back to my triage tab and I'll make sure I'm doing the right thing for the right patient. Like if I ordered amoxicillin, I will go back to my triage tab and say, okay, 12-year-old with earache. That makes sense. That just sort of to close that loop. What I ordered this, it makes sense why I ordered it. And then, good communication with the rest of your team, your nursing staffs, your techs, the patient itself. So communication is a common place for error. And a lot of times what you do is you build fail-safes in to try and prevent any major errors. I've been somewhat lucky that I have not had a major or life-altering error so far. But like most doctors, if I practice long enough, the odds are pretty good there will be a major error. And you do all you can to prevent them from happening, and you do all you can to minimize them. And then, when errors do happen, you're honest and you tell the patient what happened and how you're going to make it right. And then the large majority of the time, you remember that we are humans treating humans. And that, if I am 99% accurate, that's pretty darn good. And if I see, 10 patients a day, just using a round number, that means I'm going to make an error every 10 days. And if I work for 10 years, that's it's gonna stack up. So, mistakes are unavoidable. You do your best to minimize them, to prevent them, and to make sure to be, how you minimize and prevent mistakes is being on the same page with everybody. Be on the same page with the nurse. I'm ordering amoxicillin for Mr. Smith because he's got an ear infection. And the nurse would say, "You mean Chris, correct?" And I would say, "Yes, Chris, not Jerry." So, and then you talk to your patient and you make sure that you've tidied up all you put a bow on everything. So that's an excellent question. Any sort of questions before we wrap up to the end here? So, and if you have questions, go ahead, drop them in. If you thought this was helpful, please let me know if it was helpful or how it could be more helpful, or if you did not like something about it. For sure, let me know if you did not like something about it. Otherwise, I'm just going to speak ever so briefly about what we do in terms of like tutoring and mentorship, and from advising to the application process, to writing study plans, to content review. We've done it. I've been teaching high stakes medical exams. Oh my goodness, this is going on my 8th year now, starting with the MCAT in 2013. Now I do step 1, step 2, and step 3, and the ER shelf. So I love tutoring. I highly recommend it. You will never learn better than when you have to tell someone the right answer. You're like, that's a great question. What does that do? It forces you to learn and relearn and continually relearn the basics at details that you don't get otherwise. So this is what we do. We have free phone consults. If you're interested, we stand by the work and the services we offer. Come here, kid. Marie. Come. Say hello, kid. Oh, look at that. She said hello. Oh. So it's a good kitty. So yeah, if you have any questions, I'll leave the floor, metaphorical floor, open for another 30 or 60 seconds. And if that is the last question, then I thank you all for coming. I hope this was helpful. Very welcome to everyone who has said thank you. Just to sort of summarize, if you're interested, seek out, ways to see how it works. Otherwise, be well, be safe, and good luck. You're all going to be great.